Welcome to the Fresh RN podcast. The information contained in this podcast is meant to supplement your existing knowledge and not replace it. Always refer to your state board of nursing, standards of care, and respective institutions' policies to guide your practice. All identifying patient details have been changed to protect their privacy and remain compliant with the Health Insurance Portability and Accountability Act of 1996. Thanks, nurses. Stay fresh. Dang it, he's recording.
My mind is like in a gutter.
That's gonna lead it off.
It doesn't mean like that's what's going on in my brain.
All up in my brain.
That's not how I'm gonna use it.
And it's going to get a lot of laughs.
A lot of yucks. It all goes back to that freaking hypothesis. I wish I figured it out. The Cleaver hypothesis.
Like phalanges. Fasciculations and phalanges. It is such a nice word.
All right, we're going to try to work the word fully
Fasciculation
into each episode of season 2. I'm just picturing all of our neurodisease processes as various dinosaurs. If someone is an artist out there and a neuro person, will you please draw me a picture of a status epilepticus dinosaur? All right, welcome to the Fresh RN podcast. This is episode 14, Neuro Nursing Tips for Newbies, Part 2, Medications, Diagnostics, Surgeries, and Monitoring. I'm Katie Kleber.
My name's Elizabeth Mills.
And I'm Melissa Stafford.
So let's just jump right in. So we're going to continue our now 3-episode in-depth dive to neuro. So we're going to
awesome.
Oh yeah.
It really is.
It is.
Because I feel like there's still so much that people don't know and that we're learning and researching. So I still
Or just so much has changed. I was a neuro nurse in the ICU for 4 years, and I feel like so much has changed in like the last 4 years. I don't know. It's pretty incredible. So let's dive into some medications that are important to know specifically for a neuro patient. So we talked about TPA in the last episode. Oh wait, no, I'm sorry. In episode 13, part 1.
13.0.
13.0.
Yeah.
We took too long to explain some stuff, so we created a short that ended up being 30 minutes. So we love neuro. So we're not going to really go into depth on TPA right now. The first two, though, that I want to talk about that are probably the most important, though, are Mannitol and Hypertonic Saline. So I think those are the most important ones that as a neuro nurse or as someone who's floating to neuro, if you're administering these meds, what are they actually doing in the brain? So let's start with Mannitol. Mannitol is an osmotic diuretic. We give it to decrease ICP. This med does not cross the blood-brain barrier, and you are increasing the plasma osmolality, which is a word I always say incorrectly, to pull fluid off of the brain into the intravascular space and then out of the body.
So the fluid outside of the cell is more concentrated than the fluid inside the cell, or this. Yeah.
Yes, you're right.
And then, so the cells actually shrink.
Yes.
Because
And
they were swollen. That's why.
Yes, because the fluid shifts. Yes.
so they shrink down. It's not like they're shrinking to nothing. They're getting back to hopefully a more normal state, right? And then, so if you think about it, though, you're pulling this fluid off the brain, getting it into the intravascular volume, into the vessels. So you're naturally increasing cardiac output. So keep that in mind, that you're increasing your cardiac output. They will naturally be peeing more. So you'll have an increased urine output as well, because you're putting all this fluid in the into the vessels. So some nursing considerations for Mannitol is, naturally you've got to watch your electrolytes, right? I think the protocol was, when I was taking care of patients on Mannitol, was a BMP every 6 hours.
Serum osmo usually.
Daily?
Every
It
6?
depends. Depends on the physician, honestly. But whether it be serum osmo and or BMP, it kind of depends on what the physician's using to dose the Mannitol.
Yeah, because it's not like, okay, they get blank dose no matter what. Like, they look at how much do they need. And I believe, is it weight-based too? No, it's not.
It can be.
It can be.
Mm-hmm.
And then, so also, though, you're drawing these labs, and if they're coming back, or I guess what I want to say is know your holding parameters, right? So you're drawing labs and you want to know, hey, at what point? It's not like you just blindly give the mannitol. There's a point where it could be too much. Like I've had times where
Yes.
the serum osmo was too high. I think, what was it, like 320 or something, 330, and I called the physician. They're like, wait, actually do not give that dose.
Mhm.
Because if the serum osmo is too high, the cells can shrink and you can actually have cell death, cell injury,
Mhm.
which can cause more edema
Mm-hmm.
because those cells are dying. There's the inflammatory process. There's more swelling.
So it's quite a fine balance.
Yeah.
It
So-
is.
So it's important that you know you're holding parameters. So typically it's don't call if serum osmo is greater than blank or
Usually
whatever.
310.
310 to 320. Yeah.
Yeah, when I looked it up, a normal serum osmo is 275 to 295. So we want to push that up, but we don't want to push it up too much. So typically the one I looked it up online, what I generally found differed slightly, but was mainly typically greater than 320.
Yeah. And, you also worry about kidney injury if we dry them out too much.
Mm-hmm.
And also, when you spoke about how that increases intravascular volume,
Mhm.
just think about your patients who have a heart problem.
Yes, CHF.
Absolutely.
That's a big thing. A lot of patients have CHF.
Oh my goodness, do they ever?
So and then when I looked up the serum sodium, we do want to push it up. Like the serum osmo, you want to push it up, but not too much. So your normal sodium 135 to 145, which you should know. They're typically, if you're getting to 160, they're saying hold it, but you also need to, it's all relative, right? You need to make sure you know the trend because you don't want to overcorrect, which we talked about in the last episode. So so you can cause some renal failure because of intrarenal vasoconstriction and then that intravascular volume depletion. And two very practical things is you give it through a filter set or you draw it up through a filter needle. And if you don't, it hurts.
We've seen
Mannitol?
Mannitol crystallize. It's quite something.
Yeah,
You
actually,
know, patients on Mannitol, when you walk in, you see white little crystals on the floor,
Oh,
on your cards,
I
or
have,
whatever.
yes. Or a nurse is
Or-
taking care of a patient where they have little white
White
dots
dots
all
on
over their
scrubs.
scrubs. So mannitol basically crystallizes. So when I've had times where I get it out of the Pyxis, the machine, and it's like cloudy, and you can't give it if it's cloudy.
Nope.
You send it back to the pharmacy, and they have a process for rewarming it and basically getting rid of the crystals. So keep that in mind. But then when you give the med, I would either, and it might depend on your policy, but I would either draw it up with a filter needle, but I felt like that took too long, so I would draw it up with a blunt needle and then administer it through a filter set.
Yes, I agree. I do the same thing.
But then some people also, not everybody does IV push. I guess it really depends on
Some
the
places use infusions.
yeah. So I've heard that online quite a
Filter
bit.
it. Filter it.
Yes. No matter what.
Another thing if you are have we gotten into hypertonic saline yet?
I was kind of
Okay,
ready to go there.
Let's go there.
Okay, so
I mean, whenever.
let's go.
Ready, set.
Go. Hypotonic saline. So basically you're utilizing this medication to treat hyponatremia. So what is that? It is low sodium and cerebral edema. And actually what I thought was very interesting is hyponatremia is actually the most common electrolyte imbalance.
I don't know if I really thought about that.
Yeah, I thought that was interesting. I would think it would have been something else, but hyponatremia. And you think about it, you're not supposed to eat salt. Don't eat salt. Don't eat salt.
And here we tell everybody, eat salt.
Yeah, we're like dousing our patients' food in salt. So basically,
We had a doctor that ordered 2 packets of salt with every meal.
Really?
Yes, 2 packets of salt.
Is a packet?
It's funny because
A
neuro
gram.
Okay.
patients and cardiac,
They're so
we
beauty.
are kind of the neuro world and the cardiac world are a little bit at war because we
Yes.
allow blood pressures to be high. We allow a bunch of people to eat salt.
Oh yeah,
That's true.
We're
that
very.
is so funny.
It's just the opposite.
We're like, oh, that's a beautiful blood pressure of 192. And
And the cardiologist would be like,
oh my god, they're having their own myocardial infarction.
I mean, when you get patients who, let's say they've had some catastrophic event and they've had a stroke and an MI, I mean, it does get
Can't get
tricky.
dicey.
Yeah, it does. And I've definitely had some times where like I'm calling the neurologist, they're telling me to call the cardiologist, and the cardiologist to tell me, I'm like, y'all need to talk.
Yes.
That's right.
I'm
Please
not
do.
I'm not sitting in the middle of this.
Right.
But a little bit more about salt water. It's essentially salt water. Hypertonic saline is salt water. So some physicians will use this or mannitol, depending upon the situation, for cerebral edema. And when I looked it up, evidence really isn't super awesome to say, mannitol is significantly better for cerebral edema versus hypertonic saline, which I thought was very interesting. So it kind of,
I think there's some conflict there because there have been, as much as we learn new things, I mean, there also has been some studies that suggest that patients that we treat increased ICP with hypertonic saline don't get the same rebound increased ICP that they get with mannitol.
interesting.
So some facilities actually don't really give mannitol anymore. It's all about hypertonic saline.
Oh,
So we're still learning.
yeah, it's so
We're still
interesting
learning.
how things change.
Yeah.
So just a couple things that are really important with hypertonic saline is they will probably need a central venous catheter. They'll probably need a line.
CCVC 101.
Yes, I think that's episode 2.
That was
of
episode 2.
of season 1,
right.
guys. So check out that. But it's most policies, and actually, in preparing for that episode, I looked it up, and it's like, yeah, I mean, or actually, no, the AACN's journal, American Association of Critical Care Nurses. I got their journal the other day, and they actually had an article. Oh, I'm gonna link to it in this about using hypertonic saline in a peripheral line, because if you think about it, like, you don't want to put in a central line if you really don't have to.
Absolutely.
And if something is okay to go in a peripheral, that's priority. So they did a study, and I didn't read the whole thing, but I read the end of it, and the conclusion was like, get a central line. Which I thought was kind of cool that they looked at it, because I mean, I've had patients where they have mild hyponatremia and they're hemodynamically totally stable. Like, are we really going to throw a line in this patient for them to have one dose of hypertonic saline? You know what I mean?
Mm-hmm.
Something to consider that I would, but anyways, so keep that in mind if you're going to give somebody hypertonic saline.
And I also want to throw in there now that there are facilities that also give 23% saline. And so that's given as a
Sweet
bowl.
It's called
Jesus.
a salt bomb.
salt bomb indeed.
And have you seen it given?
Absolutely. Yep.
My patient got super hypotensive. Like, the doctor actually has to push it.
Yes.
What?
It is not nurse administered.
No,
Not.
No.
Nope.
And
Do you administer over like 4 hours? You
No,
said
it's like 10 minutes.
10 minutes. My patient got super hemodynamically unstable. They were not stable to begin with. They really got hemodynamically unstable.
And it's interesting because mine actually went fine. The 2 that I've seen given were fine. But that's important to know. And they use 23% saline for other things, but one of the things they use it for is to make 3% saline bags or 2% saline bags.
Oh.
So they actually use it, or they use it as a diluent,
Yeah.
or the sodium in TPN or PPN. But when it comes up, they're actually going to put it in our Pyxis now, which is kind of crazy. But we all had to sign releases saying that we understood the fact that it is not given by a nurse; it's given by a physician, because you can have such significant changes in fluid, electrolytes. I mean, with everything that you do, right?
Is there an order set that goes with it? I would
There's not an
assume?
order set that I've seen at this point. I don't know if they're going to create one or not, but
Monitor all their labs constantly for
Yeah.
a day.
It's
Seriously.
crazy.
it
Wow.
is. But they gave that instead of giving mannitol.
Interesting. Stuff changes so much. It's pretty cool. So those 2 meds, I think, are very neuro ICU specific.
And let me make kind of a point. When you are checking you have a central line and you have hypertonic saline infusing through that central line, pause the hypertonic saline before you start drawing your labs.
Oh, my goodness,
sweet
yes.
Jesus, yes.
And
Pause
don't
it.
draw it from that lumen if at
Don't
all
draw
possible.
don't draw it from that lumen. Make sure you do an appropriate waste, because it can really make a difference. It can really make a difference in your lab results and the patient's treatment.
Absolutely. Like, let's say you draw a lab and the lab value is falsely elevated because
Yeah.
you didn't waste enough or you didn't pause it. The the doctor's making a decision based off of inaccurate data,
Mhm.
and therefore it's inappropriate. And that could, if you especially have a neuro patient with significant issues, that could be a big deal.
And you should pause fluids anyway. You should stop your fluids unless it's like a vasoactive drug. But
Yeah.
you know,
That's a very
it's
good point.
super important when you're giving a concentrated electrolyte.
Yeah, so
Mhm.
I mean, just kind of common sense, but when you're doing a lot of stuff really fast, you can kind of forget stuff, but it's like you are infusing sodium into this person. So if you are not pausing it, you're going to like not have an accurate lab value.
Yeah.
Refer to your hospital's policy and procedure to know exactly how you do that at your hospital, but that's so important. So mannitol and hypertonic saline, those are two big ones that I think is really important for you to know. Let's see. A couple other things that we give, like we've talked a lot about blood pressure medications, or I'm sorry, blood pressure management. So we sometimes we need to bump the blood pressure up, sometimes we need to push it down. One that for trying to keep the blood pressure down that I've seen administered probably the most in the neuro ICU is nicardipine, or cardine, as we call it, on the unit.
On the street.
On the in
On
our
the neuro
dance goes.
See, sometimes I wish it's that video because her facial expressions are awesome.
Oh, I'm just wishing I had my dance goes on. Okay, so but cardine, that's a med, man. I think it's really important for you to know cardine, no neosynephrine, Levophed.
Mhm.
We don't give epinephrine very often at all in the neuro ICU.
We
Personally.
don't give epinephrine, no.
I
we
mean,
do give
That's a last
norepi a
resort
lot, but
drug.
I feel like the two main ones, blood pressure management wise, are nicardipine and neosynephrine.
I'm seeing
close
Levo.
third
I'm
of
seeing
Levo.
Levo more now than
Really?
I ever have.
Okay, and
And it may
Levophed
just
is
be position.
norepinephrine.
Yeah. No. Yeah.
So one of the things that if you have a patient that has a bleed and they have intermittently like blood pressure spikes, I think it's important to think big picture. So you may have maybe some PRN hydralazine, you may have some PRN labetalol, but what's important for a patient that has a bleed is consistent blood pressure control. So it might be more beneficial to have maybe a cardine drip at a low dose and have consistent blood pressure control instead of, here, I'm going to give 20 milligrams of hydralazine and their blood pressure is going to get back into range. And then in 4 hours, I got to give another one.
Yeah.
All right. So that's something to consider is consistent control in these patients to avoid those kind of spikes or dips, I guess. And remember with those meds, you typically need a line. Yeah, so I don't know if we really need to go into depth on those more. Do you guys have any other little info things on those meds?
I have to say that if you have a patient that's on some sort of vasoactive medication, you always need to think about what medicines you're given. But
Mhm.
if you are on a Levophed or neosynephrine to keep their blood pressure up, don't give your antihypertensive medications.
Yeah. Those haven't
Mhm.
been discontinued.
And you would think that's pretty obvious, but we're saying that because we've seen it happen many times where a
Absolutely.
patient is on a medication to push up their blood pressure and they get their scheduled blood pressure antihypertensives.
Yeah.
So, or think about you constantly, don't just take the patient from the previous nurse and coast.
Nope.
So check. I've seen patients that were on Levophed, but the pump said neosynephrine. Or I've seen patients that are on a cardine and Levophed. Like you have to, don't just coast and keep going on what happened before. Don't trust any previous nurses. Look at what they're getting. Think about what you're giving, what you're titrating, why they're on it. The goal is to get them off that stuff as soon as clinically appropriate and not just coast and get through your shift.
And also know drugs like Dilantin, anti-seizure drugs, obviously sedatives, stuff like that's going to lower blood pressure. So be very
Yes.
careful. Or just
Administering
know
too
the
quickly.
side effects of these meds. Yeah, if you push Dilantin too fast,
You can cause asystole.
yeah, their heart rate can completely, their heart can just.
Ah. I remember when I was on orientation, I pushed Dilantin, and I remember Elizabeth had told me to push it at a specific rate, and I was pretty sure I did it right. And then I had like this like moment of self doubt where I was like, oh my god, I pushed it too fast, and I ran to you, and you were like, no, it's okay, you did it right. I freaked out about Dilantin.
Even if you push the drug at the right rate, they these are still side. I mean, there's still drugs that are used sometimes foreign to the patient. So
Right. So yeah, you can have those never
just
thought
know
you'd
your
ever see.
drugs.
Yeah. So that does, a lot of patients are on sedatives or pain medications. Propofol is probably the most frequently used, or most loved, I guess, by the neuro nurses, because you can pause it, get a good assessment, and then it can kick back in pretty easily. Neuro nurses, we do love our propofol when it's needed, but we're definitely quick to get rid of it when it's not.
Yeah, that happens a lot. We'll have a patient that comes in and they're on propofol coming from another facility or something, so they need something to help them go. But the first thing I do is turn off the propofol.
Check
They
them
come in the
out.
room,
Yep.
turn off the propofol. Let it wear off so I can get a real neuro assessment.
And I would say 7 out of 10 times you don't turn it back on.
Yeah, that's probably true.
Because they don't need it. Because they're so neurologically damaged that they don't need a sedative. They don't. Okay, so any other meds you guys think we really need to dive into for a neuro understanding or a neuro perspective of?
I do think it's worth mentioning again, the antiplatelet drugs. If they're on blood thinners at some point, you need to know what it is.
Yes.
And how to reverse it if there is a reversal. We used to give FFP for everything, and then out came Kcentra.
Yes.
And then, there's another medication called Praxpine now that's available. And so it's really, really, really important to know that those medications were important for that patient at the time they were prescribed.
Mm-hmm.
But sometimes things change, and we have to reverse that.
Yeah, so maybe they were they had AFib and they needed their blood thinned so they didn't get a clot and have a stroke. Well, but maybe they fell and hit their head. So now stopping the bleeding in their brain is now the priority.
Mhm.
Yeah.
But that I have found is a challenge for patients or their loved ones to understand, because they have been educated and so consistently told how important this Coumadin is and this Plavix is, and you have to take it every day, and then all of a sudden they're in the ICU and they're not getting it anymore. And sometimes it's hard for people to connect the dots because they're so worried about
Yeah.
the bad.
They're like, my doctor, who I've been going to for 50 years, told me
I have to
take it
take
every
this
day.
every day.
Yes.
And it's like, well, you've got a massive bleed in your brain and we have to stop that. So I can't tell you how many times I've had to
I also want to mention this has come up a lot. Anyway, if you have a patient with mechanical valve,
yes,
right?
Mhm.
So they're on blood thinners.
they
Then
should
come in
be.
with yes. And then they come in with a hemorrhagic stroke. So we have to take them off the blood thinners.
Yep.
But then they've got a mechanical valve that we're not taking out. So, yes, they came in with a hemorrhagic stroke. Yes, we have to take them off their blood thinner. But now you need to recognize what happens to that mechanical valve now that they're off that blood thinner.
Mm-hmm.
So it's as with most
Fine
everything that we
line.
do, there really is a fine line.
Yeah, and you really find the cardiologist working with the neurologist to figure out
Yes.
what
And
is.
if they don't have a cardiologist seeing them, they need to get one seeing them at that,
Yeah,
Yes.
yeah, because they're
If it's
kind of stuck
something-
between a rock and a hard place. Like, do I take the risk of getting a clot on my? Because the patient with the mechanical valve needs to be on a blood thinner because blood will stick to that valve and then it will break off as a clot and it will go to their brain and they will have a stroke.
and they will have an ischemic stroke.
Mhm.
Yes.
And they can't get TPA because they already have a hemorrhage.
That's right.
So it's a delicate balance, and yeah, and it takes a lot of education with the family, because I've definitely seen that situation before multiple times. So yeah, anti-epileptics, you just got to make sure you're administering them appropriately, especially if they're PRN medications. If your Ativan says it's for seizures, don't give it for agitation. If it's your 2 milligrams of Ativan is for a seizure that lasts longer than 2 minutes. Ooh, wait, 2 minutes? Some people see a seizure happen and like, oh my God, I gotta give it right now. But it's like, wait a second, let's follow the order here. Yeah, so those are some important medications. So let's go into some scans and diagnostics. So we have another episode that really dives into the difference between an MRI and a CT scan. So we're not going to go through that here, but those are very important for a neuro patient, MRI and CT, and knowing the difference. Big thing, MRI, they can't have an MRI if they have a pacemaker. That's the big thing. And the
Most
MRI,
of them. Some of the newer ones they can now.
really?
hmm
Oh my God.
But the vast majority of them they can't.
Yes. Yeah, but you see CT scans a lot in neuro patients because that's the way that we can actually visualize what's going on with the brain, but it is
Like-
radiation. So we can't just get CTs. One time I had a patient say, well, what if we just want to get a CT every day just to see what's going on? And
They're going to glow.
they're going to glow. And the neurologist was like, so that's not how that works. I read that one CT of the brain is the equivalent of the amount of radiation as 200 chest x-rays. It's a lot of radiation, so you don't want to get that unless you really need one. So, but what I want to dive a little bit more into depth is what an EEG is. So not an EKG or an ECG, but an EEG. What is what does the EEG stand for? Do y'all know off the top of your head? Off the top of your EEG?
Now that you've said it, I can't say it.
Electroencephalogram.
There you go.
Oh, look at
Nicely
you.
done. Ding, ding, ding.
Yeah.
The prize goes to Elizabeth.
She gets the nicest donut hole at the table.
Oh gosh.
So okay. I want you.
I get the nicest hole.
That's not right.
You're gonna have to cut that out.
Can you write down the time of that one to cut that out? Okay.
We're lining that right up with my mind's in the gutter.
My mind's in the gutter.
Oh,
All
dear.
right.
So now we have to regroup and talk.
And now we're back. Okay. So the one thing I want, and if a patient is getting an EEG, it's most likely because maybe some seizure activity is occurring. So families, I'm trying to think about the best way I've noticed to educate people is when you have a CT or an MRI, that's looking at the structure of this, of the brain. But when you have the EEG, it's looking at the electrical activity. It's almost like the difference between, or actually it is the difference between an EKG of the heart and an echocardiogram. It is structure versus electrical activity. But I think families think that when you get an EEG that it's like, so can they understand what I'm saying now? Like it's not that specific.
Is the stroke worse?
Right. It's not as specific, I think, as they think it is, if that makes sense. Like the EEG, I guess it's showing brain activity, but it's not like.
It's depending on if you're getting a spot EEG, quote unquote, versus a continuous EEG too.
Oh yes, I
So,
didn't think about differentiating that.
if you're getting a spot EEG, typically lasts somewhere 15, 20, maybe 30 minutes.
Mm-hmm.
And it's going to tell you about the electrical activity of the brain during that time period. So if they're having, your patient had a seizure, so the doctor orders an EEG and they do an EEG, which is negative for seizure. What's important to understand is that doesn't mean they didn't have a seizure when you saw it. That means they didn't have a seizure at that moment when they were doing the recording.
Mm-hmm.
And I think that's one of the reasons why we're seeing a lot more continuous EEGs being used, because now we can look at the brain continuously and also look at, because most of those are also video EEGs.
Yep.
So you can see what the patient's doing clinically as well as what the brain is doing electrically. So if the patient's having facial twitches that you think are seizures, the camera picks up on what you're seeing. You mark it, and there's usually a button. You hit the button, so the neurologist knows to look at that spot. And what you should be doing is saying, I see left-sided facial twitching, or I see right arm tonic-clonic movement. Or
Not documenting I see seizures.
Right.
You can't say if it's a seizure.
Right. So, or I see muscle fasciculations in the right shoulder. That's a big
what
word.
a word.
Fasciculations. That's one of those words that I love.
Yeah, it is such a nice word.
I like that word.
Fasciculations.
It's like phalange. Fasciculations and phalange.
All right, we're gonna try to work the word
Fasciculation
into each episode of season 2. Fasciculation.
Yes.
Man, that's a good one. It's almost as good as the status epilepticus dinosaur. If someone is an artist out there and a neuro person, will you please draw me a picture of a status epilepticus dinosaur?
That would be awesome.
Roar.
All I can think of, I honestly think of like Godzilla, because then you started comparing the earthquake, and I'm like, here's the status epilepticus dinosaur
Godzilla
pushing like destroying all these buildings in Manhattan.
We should
And
write
that's
a
a seizure.
children's book to explain, because kids have epilepsy.
Concept by Elizabeth Mills.
Yes, copyright. Anyways,
Nobody else can do that now.
Yes.
Oh no.
no, actually, I say that because yesterday I was on Twitter, like
This is what's going on in my brain, friends.
It's
when I have a
Barney.
seizure.
It's Barney. I mean, looking
no. No, we can't do that. No, can't do
Barney.
that. Can't. Oh, Lord.
No, but actually yesterday I was on Twitter like I am, every day. And I saw that this guy he's a nurse. Actually, he might even be a neuro nurse. I don't know. But he's a nurse that wrote a children's book for his son to understand what he does.
Oh.
Yes,
So
I saw that.
I'm going to buy it. I haven't bought it yet, but I'm really excited about it. And I can't remember the name of the book. I'll put a link to it in the show notes, but I thought that was just so cool. And I loved his illustrations. I thought they were wonderful. But anyways, back to neuro. So that's all I really wanted to talk about with scans and diagnostics. So if you do believe your patient is brain dead, which is not like, yes, it's hard to tell if someone is brain dead. Well, I don't want to say it's hard to tell, but there's various diagnostics that vary from state to state, facility to facility to come to a diagnosis of brain death. Some of those can be cold caloric testing, apnea testing, EEG, perfusion study, lots of different things. One hospital can say the EEG and the apnea test and the cold caloric and the neuro exam, and that gets us to this diagnosis or whatever. But that can be its own episode because understanding brain death and coma is kind of
Very complex.
it is complex.
And it's ethical. There's a lot of ethical dilemmas there.
There are. So I didn't want to go into that, but that's some more diagnostics, but they're not super routine. So let's go into surgeries. Did you have something else about that?
No, I was going to try not to cough into the microphone.
So we're going to talk surgeries and procedures. Melissa, in the last episode, mentioned a thrombectomy. So can you just kind of quickly describe what a thrombectomy is? Because when I started in neuro and I'd have a patient who had an ischemic stroke, and I'd get a report, so patient came in with stroke symptoms, the CT was negative, they got TPA, and then they got a thrombectomy. And to me, that wouldn't make sense in my new nurse brain because they just got TPA. They can't have a procedure. They're going to bleed out.
I actually had that thought at first when they first started doing it too. I was like, really? They're going to bleed a lot?
Right. Or you have the patient with the intraventricular hemorrhage that gets TPA, which is also confusing. But can you talk about what a thrombectomy is?
Okay, a thrombectomy is an endovascular procedure. So they don't go in and cut the scalp. They don't go in and take the cranium off. It's done much the same way that a heart catheterization is done, most often through the femoral artery. They feed a catheter up through the groin to get up to the brain where they can give contrast and identify the clot. Now, I should mention that most of the time these patients have had a CT angiography study where they've looked at the blood vessels and identified a clot there to begin with. This isn't done across the board without clear indication for it because it is an invasive procedure. But they go up, they get to the clot, and then they try and remove that clot from the blood vessel. It's just like a heart cath trying to open up a blocked artery in the heart. They're trying to open up a blocked artery in the brain. And it's done for large vessels, not little tiny blood vessel strokes. This is where an artery in the circle of Willis is occluded by a clot. So they can go in, do things like, I don't know if I should really mention the specific devices. There's lots of different ones. But they go in, they try and get by that clot and literally suck it out so that they can remove the clot that way.
I've seen really cool videos. I'm going to try and find one to put on the show notes just so you can visually see it. I feel like Lippincott or somebody had a really good video to show it. It's incredible.
It is amazing. Sometimes they actually almost drill a hole through the clot.
Yeah.
And go through it and kind of open an umbrella almost and kind of pull back that way. Yeah. But it is amazing to see. They went through a stage where they would take pictures of the clots they pulled out of brains, and they're like, "This was in somebody's brain." I was like, "Holy cow!"
Yeah, that's amazing. Gosh, I would love to see that procedure.
And this is done at more like advanced stroke centers.
That is
this
very
is
true.
Not done just at any hospital.
And it has to be done by an interventional radiologist. It's not like the normal neurosurgeon typically, right?
They have to be an interventional neuroradiologist.
Okay.
And then neurosurgeons are also trained for endovascular procedures as well.
Oh, okay.
So, but yes, they're very specifically trained because there's a lot of risks that are associated with that. They're at risk for another stroke. So if they break off a piece of that clot and it goes somewhere else in the brain, then that can cause another stroke. They're at risk for rupture of that blood vessel that they're trying to get through, and then they end up having a hemorrhagic stroke.
Yeah.
So it's not without risks, but again, with everything we do, it's risk versus benefit, and it's so important that the doctors speak with the patients and families about what the risks are. Because when it goes really, really well, it's exciting and
It's
everybody's great
amazing.
and the patient's doing wonderfully. But I mean, I've also seen it go really, really badly, and it's devastating.
And it's to the point, typically, when you're getting to the point of needing a thrombectomy, it's like,
It's time sensitive too.
Yes,
yes.
yes, 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 yes.
you
it
can't
has
like,
onset
okay,
of
I'm gonna
symptoms
have
has to
this.
be-
and-
I think
Tomorrow,
right.
we'll see
no.
if the TPA works, and then tomorrow we'll
Right.
do it.
Yeah, no, it's very like,
I think it's 8 hours. Is it 8 hours?
Or
Or 6?
Some of it they also take into account which blood vessel it is.
yeah.
So if they're going for an MCA clot, the time window that they're usually willing to do that is a little less than, say, if it's a basilar artery clot. Because most of the time, if you've got a basilar artery occlusion, that's going to be a fatal stroke anyway. So they might present that to the patient or the family as, this is a basilar artery stroke. It will probably be fatal if we don't try this, but this could be fatal as well.
Yeah.
So they'll sometimes stretch that out further. And I had a patient a while back that came in with a basilar artery stroke, and we literally did a perfusion study to see how much of the brainstem had been stroked already, to see if it was worth trying to do a thrombectomy to try and save whatever was left.
Was it?
No, they ended up deciding that it wasn't worth the risk.
Yeah.
So, but that comes, they're combining those technologies now, because we didn't used to have those kind of studies available to us readily anyway.
It's pretty cool.
Some of the larger facilities, LA, New York, I'm sure they probably had those longer than smaller hospitals have, but it's really about using the technology to help you decide on risk versus benefit. So, but it is amazing stuff. And
Gosh.
when it goes well, it goes really, really well.
Yeah, so when I was new, it was really hard for me to understand what thrombectomy was and when those were done and how. So when you have a patient that comes back from a thrombectomy, you've got the patient that has the little dressing in their groin, and they've got to lay flat for a certain amount of time. So in keeping in mind those kind of nursing interventions, I've had patients where they didn't stop bleeding because most of the time they got TPA shortly before or whatever. So had to use like a fem stop, and which I had, and cardiac nurses are used to those because of cardiac sheaths and all that kind of stuff. So that was kind of a different thing for me to have to do. But
it's important to mention, because if they are bleeding, because thrombectomies can be done with or without TPA on board. And they can bleed with or without TPA on board. And it is the femoral artery. They'll bleed fast.
Yep.
So a quick personal story is my sister had a diagnostic study done when she was 22 years old. And they went in through her groin to do an angiogram. And she went up to the floor, and they gave her the spiel about, if you feel something hot or wet in your groin, you need to let us know. Not kidding. The nurse walked out of the room, and my sister goes, "You need to check my groin." So I looked at it, and she had probably the biggest hematoma that I have ever seen as a nurse.
whoa.
This is my sister. So, here I am laying on her groin, and she's,
The hurt's like hell.
yes.
But too bad.
But, I actually thought that she was going to wind up having to go to surgery for that. It was that bad. And she didn't, but I can tell you what, she had a bruise that went from about her belly button down to her thigh, from one side of her groin to the other. And it was really hard for her to walk for a while. It hurt.
It's a lot of blood.
So it is a lot of blood. And that was just diagnostic. That wasn't even any kind of intervention that was done. So.
Yeah. So, really important. Really important to be assessing
the groin, the pulses.
The pulses, yes, their lower back.
Yeah. They can have retroperitoneal bleeds too.
So that's a little bit about a thrombectomy. So one of the most obviously frequent ones is the craniotomy. So that's, they're like drilling into the cranium, pulling off some of it, and doing whatever surgery they need to, whether that be an aneurysm repair, tumor removal, evacuating a subdural. There's lots of reasons they could need to access the brain surgically. And then there's also the craniectomy, which is removing part of the skull and leaving it off to allow room for swelling, because remember, the only place they have room to swell is down into that foramen magnum, which it will result in brain death. So, so they'll take that off. They'll keep the cranium piece somewhere safe, far away from me up in the ICU.
Well, sometimes it's in a freezer. Sometimes they put it in the abdominal cavity.
Oh,
I mean,
yes. Isn't
yeah.
that can you explain that real quick?
Yeah.
Yeah.
Not
So
really, because I haven't experienced that, because in the facilities that I work in, most of the time it goes into the freezer in the OR, but
right.
they do sometimes put that piece of bone into a little pocket that they make in the belly, and the thought is it's sterile, if you will, and inside the patient's body.
It's not going to get lost.
It's not going to get lost. That's true. And then they come back for it later. But I actually kind of would like to see that in real life. I know it exists, but I haven't personally experienced that.
Yeah. Oh my gosh. And our Kieran, who helps us with sound, his mind was just blown. His face was pretty good.
Not to go off subject, but have y'all heard about the new organ that they have like defined in the intestine,
I
the
read something about
mesentery?
that.
It's
Yes.
like it's crazy.
I
It
knew,
just I think of it as just adipose tissue.
but yeah, no, it's the mesentery. Yeah,
It
yeah.
holds the abdominal wall,
Mm-hmm.
or it holds the intestines to the abdominal wall. Anyway, totally off subject.
Oh, but that makes me think of one other thing. Quick off subject is that in September of 2015, researchers kind of stumbled upon the autoimmune component of the brain, or the immune component of the brain, because previously it was thought that it was kind of not part of the immune system, but they actually found lymphatic ducts in the brain.
It's pretty cool.
Which I thought was incredible. And I'll put a link. There's tons of articles about it because people are pretty much
I like neuro.
yeah, pretty geeking out about it, which I was doing, like, no way. So I'll put a link to that. There were many articles about that, but anyways. So yeah, so a lot of your neuro patients may have that surgery. Typically after you have that brain surgery, watching the incision for infection, watching their blood pressure that first 24 hours is important. And then one thing is, a lot of people think I have this big cut in my head that I'm gonna have a lot of pain, but surprisingly, there's not a whole lot of pain. There's not a lot of pain receptors up in your brain, and patients that have like brain surgery typically have significantly less pain than like a knee surgery patient or a hip surgery patient.
Depending on the kind of surgery they had, that's true, because most of the pain receptors are in the scalp.
Yeah.
So it's usually incisional
yeah.
pain, not
Not like all up in my brain pain.
all up in my brain pain. Katie's been in North Carolina for a while now. You can tell.
It is knitted to my soul. Let me tell you.
I'm gonna
All right.
auto-tune that later. It's gonna be brilliant.
There's not a lot of
I love
brain.
in my brain.
Pain in my brain.
What? Okay, but now let's talk about drain placement, EVDs. I love EVDs, but I also hate EVDs. Patients will have, so we talked about it in the last episode about how if you have a lot of pressure, you you drill a hole into the skull, which is oh so cool to watch.
Yeah, if you don't have neuro nurses in the unit, they'll be like, "Can I watch? Can I
Yes,
watch?"
yes. Or you'll have people that say, "I never want to see that.
Yes.
I'm gonna go over here now," and they put a catheter in, relieve pressure, and then basically what you're doing is draining cerebral spinal fluid because the body cannot reabsorb it. So it's based off of gravity. So it's leveled to us depending upon where the physician orders it. So what's the 10 above tragus is normal?
Tragus, they may use lateral canthus, but kind of what they're going for is the foramen of Monroe, anatomically speaking.
Which is technically, isn't it the same? If it's tragus or lateral canthus, isn't it still the foramen?
Mm-hmm.
That's what they're going for, is the foramen of Monroe.
So if you screw it, well, I'm not going to go there.
No, don't.
Don't go there. So they're pretty cool. So basically head of bed is really important. You can't have someone all of a sudden hop out of bed or put their head of bed down, because it changes the pressure quickly. Yeah. So that's really important. So having your mind around your orders and stuff is really important.
It's so important. That change in pressure can be fatal.
Mm-hmm.
And so it's so important for you to know if the x-ray team is going in your patient's room to get a chest x-ray, or speech therapy is going in there for a swallow eval. I
And
mean,
they're-
everything. It's so important that the family understands they cannot adjust the head of bed. I mean, it's so pressure dependent, and if you have that shift in pressure, it can be so severe that it actually causes bleeding in the brain and can be fatal.
Yes.
And it's serious business.
And I think so. Usually, hopefully, your therapy services and people that are coming into the neuro ICU know that this is the one unit you can't just go into the patient's
And do
room
what
and
you
do
want.
anything. You have to touch base with the nurse because of that.
Mhm.
Hopefully, but I don't know what their training's like. But one of the things that I think is really helpful is to have signs. Because
Absolutely.
sometimes you're in a room with another patient and a brand new family member comes in that hasn't gotten the don't move the head of the bed spiel. So, like I actually, recently, or no, I guess that wasn't recently, but there's this big thing, no paper on the wall, no paper on the wall. But
Mhm.
that was the one piece of paper that was
There's
allowed.
no handwritten signs too.
Yes. Oh, that's true. But so that is, we can't even begin to say how important it is. And that also, that device can be hooked up to intracranial pressure monitoring,
It
which
can.
let's go ahead and flow into monitoring, but we're going to talk about ICP monitoring first. So normal ICP is 7 to 15. You start to get kind of freaked out about 20 to 25, like, hey, y'all, we need to do something about this kind of thing. But that EVD can be hooked up to the ICP monitoring. And then another aspect that's really important is also cerebral perfusion pressure. So
Monroe-Kelly hypothesis.
what? Everything, it all goes back to that freaking hypothesis. I wish I figured it out. The Cleaver hypothesis.
That'll be the dinosaur. Oh no, that's Elizabeth.
Roar. Okay. So the way you figure out cerebral perfusion pressure is their MAP minus their ICP, and that is their cerebral perfusion pressure. And do you want to talk a little bit about what that is, why that matters? It is essentially what it sounds like.
It's basically the blood pressure of the brain. I mean,
Yeah.
honestly, blood pressure is the blood pressure of the body. CPP is kind of the blood pressure of the brain. And the thing is what you have to think of, it's MAP minus ICP. So if your blood pressure is really low
Mm-hmm.
and your ICP is really high, think about what that means for your cerebral perfusion pressure. So that is really the reason why we allow and usually prefer higher blood pressures,
Mm-hmm.
is so that we can maintain cerebral perfusion pressure in the setting of an increased ICP. Because basically all of our patients have an increased ICP.
Yeah.
We may not know the number, but they're either there for a tumor or a stroke or a bleed or whatever. So they have an increased ICP. We need to protect cerebral perfusion pressure.
Mm-hmm.
So generally speaking, we need it to be. They're actually kind of changing the parameters these days, so I don't know if they're actually published or not. But
So therefore, do not
do
quote us on
not
this.
quote.
Do not answer an NCLEX question based off
on
of this.
No, do not do it. But somewhere in the neighborhood of 60 to 70 being okay.
Mm-hmm.
If you have cerebral perfusion pressures, definitely that are 50 or less for any period of time, you're going to have significant brain issues.
Because it's not getting the amount of blood it needs.
That's right. I mean, you've got cerebral
not getting-
ischemia there. They're
Mhm.
not getting perfused. So, the same thing goes actually. Just because their CPP is high doesn't necessarily mean that's great either. So, if your blood pressure, if your MAP's 105, which is not that uncommon in the neuro world, right? And your ICP, because you've got a ventric, is actually somewhere around 10. Well, your cerebral perfusion pressure, right? I said 105 minus 10, so 95. For a little while is okay, but if you're constantly having that high CPP, there is some suggestion out there that they may have other side effects, not necessarily related to the brain, but related to systemic thing. I actually just read an article last night about if it's kept too high for too long, they're at higher risk for developing ARDS. So, and I thought,
Interesting.
really? Huh. Doesn't really make much sense to me, but I'll have to, I'll have to wrap my brain around that. But,
Yeah.
Um,
So as you're saying that though, and mentioning yet another article, and all we do is mention articles, is how important it is to stay tuned into that stuff, because your best practices and things change, or something I would have never thought that would be related to ARDS or could have any relation to ARDS at all.
No, not at all.
So be a member of your professional organizations, people. Get those journals. Stay up to date on that kind of stuff.
Mhm.
So sorry.
No, it's fine. I mean, that's the biggest thing. MAP minus ICP. So you need to make sure you understand that why you're keeping your blood pressure where it is, especially based on what your probable ICP is.
And ICP is an invasive monitoring thing. It is not like blood pressure or NIBIT or something or heart rate. They have to have something drilled into their scalp or into their skull for you to get this measurement. So they will only order this if it's absolutely necessary. Like if the risk of putting in the bolt, which I'm not sure how often is done.
It depends on if you're a trauma center. Bolts are much more common in trauma centers.
Because they really want the number. Absolutely. A bolt is basically drilling in just to measure, not to drain anything, but just to measure. And we're not a trauma center, so I don't have a ton of experience with that. But they don't get this number just for the heck of it, I guess is what I'm trying to say.
Risk versus benefit.
Right. I think those were kind of. And the other one, vitals are very important. We've talked about blood pressure, but body temp in neuro patients, I cannot tell you, I can't begin to describe how important it is to you. It is absolutely essential in a neuro patient. 101 fever in a patient with a neurological injury is way worse than someone without one.
Yeah,
generally.
I mean, there's been some suggestions that perhaps for every degree of increase in body temperature, the oxygen demand for the brain is like increased by 10%.
I have read that as well. So yeah.
And it might be half a degree. But so in my world, in the neuro ICU, I'm typically going to treat a fever of 99.5, whereas in the medical ICU, they probably won't treat it until it gets 101.5.
Right.
So it's really important to understand that. And the other thing is that these neuro patients will have neuro changes based on that fever. So, well, I just might not feel good if my temperature is 101. A neuro patient may be more comatose.
Right.
So.
Yes. So it's important that when you're getting your vitals and you're checking your temps, and actually it's really nice because some things have continuous temperature monitoring, like your Foleys have temp sensing, or you have endotracheal monitoring or rectal as well, which is really nice to continually be able to see it.
Yeah.
But treat those with your orders appropriately, but it's imperative to be more aggressive with temperature management with patients, in neuro patients. I do have a link to in my notes that I'll put on the show notes that I can't remember where it was, but neuro injury and fever strongly linked to poorer outcomes. So I thought that was a really good article. I have it linked. So check that out. So I think did you guys have anything else that you wanted to say for the new nurse in neuro as we round out our little neuro series?
Good luck.
Neuro's great.
We
Neuro's
love it.
Great.
We're
Neuro's
passionate.
Great. Be patient. It's a lot of information to learn.
Yes.
The longer you stick with it, the more you do it, the more comfortable you'll feel.
Yes.
Look for a mentor, even when you're done with
yeah.
orientation.
Look for a mentor. Seek guidance from your more experienced nurses.
And get good at that neuro assessment.
And if you have questions, I don't know how many times I still go to a nurse and say, hey, will you come look at this? What do you think about this?
Oh, I do that like Q12 minutes. Even into my
not a silo. We have, you know what I mean? Like
yes, team nursing. It's a team atmosphere. If you're not sure about something, pull another set of eyes in. You're not going to be perfect. Like, really important. So, and neuro, it's really important to have other people take a look and that kind of stuff and working together. And there are no stupid questions.
No, never.
Like,
ever.
Is the subdural a stroke? That is not a stupid question.
No, it's not. There's so much, and I'm sure in these 2.5 episodes you've detected that a little bit, but there's a lot to know, and there's no way. I'm 15 years in and I'm still reading stuff and learning stuff, and I don't expect not to ever be learning stuff and reading stuff. So please ask, please research.
All right, well, thanks guys for listening. Check out freshrn.com/podcast for some show notes and links to some of the stuff we've mentioned. And thank you guys so much for listening. Stay fresh.
Damn girl, better hit the floor. All the other fellas better